AT is a recessively inherited genetic disorder affecting many systems of the body. The name comes from two of the main symptoms. The first one is the ataxia, and this is loss of coordination in walking, which is often the first symptom noticed between the ages of 2 or 3 years. If this is seen in association with the telangiectasia, or the prominent blood vessels in the whites of the eyes giving a bloodshot appearance, then the neurologist may well think of AT. Other things that can happen in AT are immune deficiency and a predisposition to cancer developing at a young age. We know that the condition comes about because of a faulty gene on chromosome 11. Parents unknowingly carry this change, although they're healthy themselves, but if they each pass on the change to a child, which is a 1 in 4 chance, then the child has no normal copies of the gene to compensate and therefore is affected. The gene's function is complex, but it's integral to cell cycle pathways, particularly DNA repair. And also it's involved in apoptosis, which is programmed cell death. Overactivity of that will lead to loss of nerve cells particularly. This is what happens in the cerebellum. The loss of Purkinje cells in the cerebellum lead to the ataxia. The actual effects on the immune system are less well understood, but the fact that it's a multi-system disorder must mean that it's a crucial protein in all types of basic cell function.
The problem clinically is its rarity. Child neurologists like me will see a case perhaps every 4 or 5 years. A district general paediatrician maybe every 10 to 15 years, and a GP perhaps never in a professional lifetime. So it's important doctors in clinical practice recognise the early signs of this condition. Most children with AT present to doctors with motor difficulties at the end of toddlerhood, school entry sort of age. And the difficulty as presented is usually clumsiness, which is a very common presentation of many children. Now, clumsiness in girls is a bit of a worry. Girls develop more quickly than boys, those rumours are true. And so if you see clumsiness in a girl, you should think, is there an underlying neurological problem? Do they have telangiectasis? In a boy, it's much less worrying because 1 in 15 boys are clumsy anyway. Nonetheless, these children carry a characteristic clinical hallmark that's very important to emphasise, and that's known as an oculomotor dyspraxia. What they do is they tend to follow the object with the head, leaving the eyes behind them, and then when the object stops moving, they restitute the eyes on the head with a sort of characteristic flicking of the head. So if doctors see that, they ought to think AT.
Our role in the diagnostic procedure is to try and confirm the clinical diagnosis of AT by using various laboratory tests. First of all, we like to obtain a blood sample just in lithium heparin from the patients, just a few mils, 5 to 10 mils, and with that sample we can do everything. First of all, we look at the chromosomes of the patients, and we know that in their peripheral blood cells and their T lymphocytes they have translocations which are present there. They also are very sensitive to X-rays, so we expose some of the blood to radiation and count the amounts of damage that are present in the blood and compare that with normal. And that will actually tell us pretty well straight away whether this person is likely to have AT. Now, AT is quite complicated because occasionally some patients do produce some protein, and this may depend on the type of mutation that they have. So the amounts of protein present can vary from nothing to a substantial amount, but always less than you would expect to see in normal.
Does the AT affect the immune system? Yes, in about 80% of patients there is some degree of deficiency of the immune system. This is very variable from case to case, but in many it will result in an increased susceptibility to chest infections, ear infections and sinus infections. What sort of germs do patients with AT get infected with? Well, bacteria are a common cause of the problems, and that's particularly bacteria which are polysaccharide encapsulated. And what I mean by that is that they have starchy capsules made of polysaccharide around themselves, to which the body needs to mount an antibody response. And we know that AT patients have great difficulty in mounting an antibody response against polysaccharides. They also have a susceptibility to viruses, and these can lead to a different spectrum of infections. And a good example is chickenpox, which can behave in a much more aggressive fashion in a child with AT compared with a healthy, normal child. So what can we do to reduce the burden of infections in these children? Well, the mainstay of treatment is to give the patient a continuous antibiotic prophylaxis. That involves taking in a low dose of antibiotic continuously to try and reduce the likelihood of bacterial infection in the chest and the ears and so on.
Why do people who have lost this ATM gene have this increased risk of developing cancer? What is the relationship between having no ATM gene and the risk of cancer? And some progress has been made on that over the years from us and from other people as well. But that still is our main role. Leukemias do develop in these AT patients, and so we have to be prepared for the treatment of the leukemias. If we know that these people have ataxia, telangiectasia, then they can be seen frequently and diagnosed with the leukemia at the earliest opportunity. Something again like 15% of all children with AT will develop a lymphoid tumour. So it's a disorder that affects a very wide number of systems in the body, and extremely serious and progressive.
Once the diagnosis is secure, then the important thing is to give the family the news of that as quickly as possible, following what I hope now are well-established guidelines. They can then be helped with the readjustment and readaptation that necessarily follows.
We thought we had a normal child for 3 years, and then of course you realise that you've not.
It's nice to see somebody that knows what they're looking at and can talk. When you ask questions, they can give you answers to what you're looking for because they see it on a regular basis, whereas where we live, nobody's really seen it before.
Once a child with AT has been diagnosed, sometimes the parents will ask, well, how can we avoid having another child with AT? And if the genetic workup has been done in both the affected child and the parents by blood tests, then very often we can offer a test early in a future pregnancy to see whether or not that baby is affected. And then the parents can decide, obviously, whether or not to continue with the pregnancy if it is.
A word needs to be said about how doctors can effectively liaise with education authorities to maximise opportunity for young people with AT. In the same way that families initially need to know about the condition, so do the child's teachers, and local community paediatricians can be tremendously helpful in providing that sort of information. Then the classroom becomes an area which too can offer good opportunity and encouragement once the teacher's adjusted to a slightly differing set of circumstances.
The social implications are for the family are huge, really. Apart from the initial devastation of the diagnosis of AT, they have to accept the fact that this child is going to probably need lifelong support in terms of they won't lead an independent life. Although some of our older patients have done extremely well and are managing to go to university or sort of travel and things, but the family always need to be there as a support. But there's quite a lot that can be done in terms of therapy in their overall management. This is because children who are losing their mobility tend to suffer from postural problems such as curvature of the spine or contractures of the muscles. And obviously physiotherapy can be invaluable in preventing these things happening. At the moment, there's no cure for AT. Things have moved on a lot in the last 10 years in that we've identified where the gene is on chromosome 11 and what the normal function is, or at least how it's involved in the cell cycle pathways, DNA repair, and the immune system. So our understanding is a lot better, and one would hope that that would then lead on to more effective interventions in the future. However, at present, it has to be said it's limited to managing the condition in terms of treating infections, treating cancers if they arise, which is sometimes successful, and maintaining mobility for as long as possible.